So, gentlemen, I will start with you, Joaquim. There's a shift. It's happening in these past 2-3 years. We're seeing some new data evolve. What do you think, bigger picture, is going to be the future with regard to understanding better the biology of the disease and to drive decisions with all the new agents that are being tested?
Yeah, you're totally correct. So we have been not getting any new data for the last 30 years. And we're watching prostate, kidney, and since 2014, when the first papers on immunotherapy in patients heavily pretreated came up, it was published in Nature. Phase 1 trial published in Nature means something. And then, thanks to the TCGA, that we have been able just to get genomic information on bladder cancer. And we need to remember that we don't have any targeted therapy approved for bladder cancer. We know that there are targeted therapies for breast, for lung, and so on. And now we are having immunotherapy as a new option, and new targeted therapies, mainly for targeting the FGFR receptors, and we are going to hear more about that. But hopefully, I think the field is going to change. Also, new agents that are named the antibody-drug conjugates that are like a type of targeted therapies similar to the TDM1 that is being used in breast cancer. So with these 3 set of agents, the landscape is going to change. So we're going to discuss today about the clinical trials that are ongoing, and I assume that in a year, the landscape will be completely changed.
So let's take first line, metastatic urothelial carcinoma treatment. You're saying everything's going to shift very quickly? Peter, what do you think?
I think, as you said, there are 2 major directions. One is the development of new drugs, and the other is the development of a new understanding of bladder cancer. So we are not treating bladder cancer, we are treating bladder cancers. So all these various subtypes, and they haven't been addressed in all these trials yet. So there will be a more personalized, as we see in kidney, as we may see in breast. We haven't seen that in prostate, by the way. So there are not all these subtypes, despite the neuroendocrine subtypes. But I think we'll see this shift towards a more personalized or more in respect of the subtypes in bladder cancer. That is one direction. The second direction is that we realize that checkpoint inhibition is one of the real advantages also for bladder cancers. And in addition to that, I think what we are now seeing in second line and hopefully moving into first line, because these alterations are there already in first line, that may be an interesting development towards targeting
tell us
alterations.
A little bit about second line. Where do we stand?
So
right
FGFR, for example, for these checkpoint inhibition is one. As you said, the enfortumab, all these drug conjugates. There are interesting new developments. Beyond chemotherapy, which was vinflunine, which is not licensed in the U.S., but it was the standard of treatment in Europe. And I think looking at the data, we see the checkpoint inhibition there, but we also see all these more targeted drugs that are used there, and they are beneficial for these patients. And I think the development in second line needs to move further into the first line, as we see in all other cancers. So we start with first line development, second line development, right. and then
but let me, for us who are not so much in the field of bladder cancer, understand it. You just mentioned earlier, and we saw this beautiful data in prostate cancer changing the survival in hormone naive with the addition of novel agents. We see this delay in metastases. Are you starting to get a glimpse of similar effects in a disease that's completely different, of course, with a very short natural history? Are you seeing such changes happening?
Yeah. If you look at the landscape of current ongoing trials, you see more and more neoadjuvant trials being executed, and you see basically that is a sign of moving into earlier treatment, so prior to cystectomy, which still is the standard of care, but we are treating these patients prior to the operation, and I think that is a good sign towards earlier treatment and a more complete picture, a multimodal treatment where we start to do systemic therapy very early, then add the operation surgery, and then we may even continue. So it's more a perioperative setting we are now aiming for, and I think that's a real change.
So, and in the metastatic setting, Joaquim, do you see this change?
Yeah, so what we have as of today, until recently we only had bimfluorine. Now we have level 1 evidence that immunotherapy is prolonging survival in our patients in second line. We have data that these agents are useful in first line and able to receive platinum-based therapy based on the PD-L1 staining, and we need more data on that. And I think what we're going to see this year is that we're going to get the readout of at least 3 trials in first line that have completed the accrual.
That's what I was going to ask you.
That's
we're going to get data this year.
At the end of the year, we hope that we're going to get the results of the Keynote 361, that is with pembrolizumab combined with chemotherapy, so meaning immunotherapy plus chemotherapy, similar design made with atezolizumab, and maybe we're going to know about the DANUBE trial that is combining a PD-L1 plus a CTLA-4, and there are two other first-line trials that are completing with nivolumab and also one with durvalumab and chemotherapy. So we have 5 phase 3 trials, 3 completed, and these 3 we will get, probably those are going to be practice changing. Also, at the end of the year, we're going to know the results of the adjuvant trials with immunotherapy. So the IMvigor 010, that is the adjuvant atezolizumab trial that I'm involved in, this is what I know, hopefully you are going to get results on the role of immune therapy in the adjuvant setting, meaning patients that have failed neoadjuvant chemotherapy or patients who are non-eligible for neoadjuvant or adjuvant chemotherapy, and we'll see if there is a survival benefit. So a lot of changes. And the last thing, we know that the targeting FGFR alterations got breakthrough designation. It's not only erdafitinib, it's only for the B701 compounds and all these agents, despite not having yet phase 3 data. Probably these compounds, because the benefit is clear, will move forward.
And with that example, you see, they're actually catching up and they'll do better than us. We've reached a little bit, and you've seen it, a plateau in prostate cancer with just hitting the mark for a lot of androgen signaling inhibitors, and otherwise we're in like a steady state, but we're not moving forward with targeted therapies. Do you anticipate, and of course you gentlemen, anything in prostate cancer that will be groundbreaking this year? I know we mentioned before that we got a press release on apalutamide again. We're going to hear data, but groundbreaking, practice changing. Do you anticipate anything?
I don't know exactly on the timeline, but probably in the field of hormone-sensitive metastatic, where the addition to with androgen receptor signaling inhibitors with chemotherapy will probably even the combination.
But still no other types of mechanism of action?
No, I think when it comes to individualized medicine based on genome sequencing, let's say the PARP inhibitors, I think the trials are ongoing, but the signals are kind of confused whether to use it in combination with or without a mutational status. I think it's a long way to go.
Well, this is actually a segue to my next kind of topic of discussion that I'd like to bring up to all 3 of you. So more and more data, more and more information, more and more genomic information, and also we're getting in our clinics germline testing, genetics, and the like. Patient communication. It's not just now about describing how a chemo or androgen deprivation or what have you be. Now we're introducing more ideas and thoughts. How difficult is that getting, and how much should we be focused on patient communication?
Exactly, it's getting more complex because we have, let's stay in the hormone-sensitive metastatic. I think that's the most demanding field of patient communication, because the patient used to be healthy and now he is sick and is faced with a deadly disease, and we have concepts to help him. they are associated with good quality of life, and they both work. So how to counsel in the one or the other direction. I'm talking about chemotherapy or abiraterone. So it takes time to weigh the advantage or the disadvantage of each treatment options, and to have to look a little bit downstream what will be the potential next drug that will be available. So we need to take more time. And of course you need to be an expert, you need to know the data, because the patients are demanding and they are going into the internet. They come with a lot of information. Some is valid, some is invalid. It takes some time to sort it out. It's very important to have relatives with them.
Well, I think that this is a topic that we're going to discuss today, the patient communication. And sometimes you are facing with three different types of patients. Those that are not willing to know more than you are telling them. Even they say, well, don't tell me about that. This is more or less 50%. There are others that, let's say it's 40%, that they are coming with information from internet, well-instructed patients that are asking really smart and clever questions. And then even there is this 5% that they are even providing you data that you are not even aware, and you need to say, okay, let's check. So patient communication.
So there's nothing wrong with that.
Nothing wrong.
I haven't looked at that.
Absolutely.
So that's it.
That's a great thing. That open the door and not being paternalistic. That is the way that medicine was being done in the past. And you need to sit beside the patient. This is something that in the US we know. There is not a table in between the patient and the physician. Right now we are sitting together and let's check the data and discuss what needs to be done.
There are even companies out there, as we heard yesterday when we had an AI discussion, that are looking gradually and trying to pick up clinical trials for patients across the world. Peter, do you have a comment of all this advancement in technology and how patient communication will go?
I think what is interesting, we are always talking about personalized medicine, and we think it is linked to alterations, molecular alterations, and specific drugs for these patients. But what we are doing in prostate, for example, is already personalized medicine since decades. Personalized, for me, in this setting means that we talk to each and every patient differently, according to his specific needs, his expectations, our possibilities to really treat this patient. And I think if you look at 10, 15 patients having prostate cancer, you probably, although you have all these substances available, all these treatments available, you treat each and every patient differently. You do personalized medicine already in a more holistic way. And interestingly, with the possibilities we are adding now through all these new drugs, new availabilities, new possibilities, new imagings, new therapeutic things, I think it simply adds to the armamentarium we are having for these patients. But we are doing personalized medicine already for decades.
I think that this was an excellent summary of the whole discussion. We may not have biomarkers, words of wisdom. We may not have biomarkers, but we have a duty to listen to their needs and personalize based on the needs of these patients. Thank you very much, and I trust we will continue to all do so.